Alrighty, well, I think we'll make a formal start now. As I said, I dare say we'll expect a few more people to join us as we come and go. But I'd obviously like to start the morning by welcoming everyone. I really appreciate everybody who's given up part of their day today to be with us as part of this particular event. It's been a few months in the making and planning, and we've been very excited to bring it to you, both from perspective of the School of Health Sciences, but also Centre for Digital Transformation of Health. So I'd like to quickly introduce myself. Of course, I'm Mark Merolli. I'm a physiotherapist. I'm a senior lecturer in the School of Health Sciences here at Melbourne Uni and a research fellow in digital health as well. And again, I'd like to thank you all for attending today, what should be a very informative and interesting session with lots and lots of interest based on registrations and communications and contacts we've had about the event. Before we dive into the formalities of the day, I'd also just like to briefly start the day by paying my respects to the traditional custodians of the land. I know we're all meeting from different corners of the state, of the country today. Where I'm tuning in from is the area of the Wurundjeri people of the Kulin Nation. I'd like to pay my respects to elders past, present and emerging. So again, I'd like to welcome you all. Clearly, this sort of event, a topic like digital health, has become very, very topical. For many of us on the line today that will have been working in the space for some time now and have been doing good things in this area, be familiar with this area. And for others, since COVID-19 has hit, you may feel that you've been just thrust upon into it. The thing to say about digital health is that it can mean so many things to so many different people. And in many, many ways, that is very true. For some, it might mean working with data or the data science end of technology and healthcare. And for others, it might refer to how healthcare is actually physically delivered. And we don't have to look very, very far past COVID-19 and things like telehealth, for example. We could be talking about a range of connected devices in that sense. So smartphones and apps and various wireless monitoring devices. You could work actively with electronic medical records, the internet, and the online patient portal and social media space, virtual reality, robotics, and the list goes on. Of course, no matter what your area of interest is, I think we're all here with a common goal, and that is to improve health outcomes for people, to make healthcare more effective, more efficient, and safer. So, Basil, I might ask you just to skip ahead one slide. I'd like to just talk to you all about the timetable for our day. A little bit of Zoom hygiene. You will find that you are muted and your video is off. That's just for us to help us manage the event for today. So please keep those settings as is. Our speakers will be the ones that are able to unmute and turn on their video. I will ask you all, if you do have questions, and please engage, please be active, to post any questions as we go during our sessions, during our lightning talks coming up, during our panel in the chat box. And we have people moderating that and keeping an eye of that as we go. I will just lastly mention that the event is also being recorded. You'll see we're going to jump into our lightning talks shortly with our representatives from our different departments, followed by our panel. We'll then have a break to give you all a chance to rehydrate, to have something to eat, to perhaps answer some of those emails that are going unanswered while we work this morning. And then we're going to jump back together. Some of you have registered interest for the workshop, the ideation workshop that's being run by the Centre for Digital Transformation of Health. That'll get started at 12:30 and run till 2 o'clock. And for those of you who are trying to build a track record, a research career, that goes to all walks of research maturity and career tracks, please join us at 2 o'clock. Bring a cup of tea, a coffee, and have a chat with some of our more experienced mentors in that space. So I'd like to now take the opportunity to briefly introduce our head of the School of Health Sciences, that is Professor Linda Denehy, and she'll no doubt mention to you all how digital health fits within our school's wider research strategy and help perhaps consolidate why we're here today. So Linda, if I could flick to you, that would be fantastic.
Thanks very much, Mark. I'm really thrilled to be able to open this, and I would also like to acknowledge the custodians of the land in which I'm on, and it's also with the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present and emerging. So thrilled to be opening a digital health seminar and conference, and also thrilled that it's been so successful and so popular with so many people registering, a couple of hundred registrants, I understand, for different sessions, which will be fantastic. The School of Health Sciences in the last few years has developed research hubs because we're a school of 6 disciplines, 5 allied health and 1 nursing. And so it's very diverse, lots of variability, but all with the outcomes of improving health for the community in which we serve, which may be different in the different allied health areas. So what we did was we designed some research hubs to bring all of our disciplines together across the school. And we have 3 research hubs now, and really we're just getting started with this, and we're really just also fixing our web, another digital area that's very important, to reflect our research hubs and other things. So we have 3 hubs, and these are Healthy Start to Life, Optimising Health and Wellness, and Disability and Inclusion. And those 3 hubs really pull together everyone across our school. And so that we can do more interdisciplinary research, which I think, you know, out there in the space of the community, in primary care and in our hospital systems, we work in teams. We don't work in silos. So that was one of the ideas behind the hubs. The other idea is, of course, to improve our research successes by asking fundable questions and getting everyone's brains to think about that. Apart from the 3 main hubs, we have 2 cross-cutting themes, and we decided on these, must have been about 3 years ago. One of these is implementation science and the other is digital health. So we have recruited to extremely well, I may say, to both of these areas to really grow these cross-cutting themes, because they're part of each of those 3 hubs and part of all the research that we're really doing in the School of Health Sciences. So implementation science, we will be having a seminar like this, but probably early next year, with Professor Gillian Francis, who's our new implementation scientist leading the school. When it came to digital health, we were really, the timing was just wonderful, because Professor Wendy Chapman had just come from overseas to start up her Centre for Digital Transformation of Health. And so we got together and have a joint appointment, and we appointed Mark to that joint appointment. So I'm really thrilled that we can work with the centre through Mark and collaborations. And Wendy and I also meet around collaborations around other things as well. So timing's everything in business, I think. And so we're extremely lucky to have Mark, who is a physio, so he's an allied health person. He also did his PhD in health informatics. So he's a really perfect person to come into the school, collaborate with the different departments within the school, and also within the Centre for the Digital Transformation of Health. So we're thrilled that we have these 2 cross-cutting themes. And I note on Mark's website, we're in good company, because the World Health Organization has named digital health as an area of strategic importance. So we're rubbing shoulders and doing the right things, I think, for our future, because I do think our future is in both how we implement our research findings for the betterment of patient outcomes. And part of that implementation will be using and implementing digital health. So this seminar is really important. We have advertised it widely across our partners. So I do hope that some of our partners are online and joining us today from MAC hospitals, from all sorts of different areas in the faculty and in the wider university. So I'd like to welcome everyone and hope that you participate, because after this morning's session, the lightning talks ask questions, then the afternoon sessions are around more participation. So please do so, and thank you very much for your interest. And I'd like to officially open this, our first seminar in digital health from the Melbourne School of Health Sciences. Thank you, Mark.
Linda, that's perfect. Thank you very much for opening us there. That you've put it perfectly as far as the school's concerned, and hopefully we can build on that strategy. So it gives me great pleasure now. I'd like to also now briefly introduce Professor Wendy Chapman. As Linda correctly stated, Wendy's our Associate Dean of Digital Health. She will also be leading the research ideation workshop at 12:30 for those planning on joining that session. So Wendy, I'd like to flick to you, if I may.
Yes, it's such a pleasure to be here. And like Linda said, timing is everything. And it was great timing for me to be able to discover this job. I moved here from the University of Utah, where I was the chair of biomedical informatics. I have a degree in medical informatics, and my research area is natural language processing and extracting information from clinical notes. But as I worked on my research, I just felt like the impact that I could have working in that area was very small. And I felt this passion that I wanted to be able to impact health in a larger way. And so that's why I took a chair position, a more leadership position in digital health, in informatics, and then found this position here at the University of Melbourne. The center is a large investment from the university in this area, and it's cross-cutting, and so it's through the Faculty of Medicine, Dentistry, and Health Sciences, but also the Engineering School and the School of Computing and Information Systems. And so it's meant to be very horizontal and support collaboration across the many disciplines that are required to really transform health in a digital way. And I think that another thing to note, like Mark said, that what digital health means is different to everybody. But we're looking for a transformation of health with the lens of how data and digital innovation can help do that. And so it's not about the technology, it's about the transformation of health and using the techniques and the information that is stored in digital forms to do that. So we have 3 missions. One is education, one is research, and the third is impact in the health services. And so we're trying to build partnerships in the health services as we develop research and education activities. So really looking forward to hearing about the many wonderful ideas and projects that people already have, and in piquing the interest of those of you who know that there's a role for this in the future in the transformation of health and want to get involved but don't quite know how.
Okay, thank you very much, Wendy, and I'm sure people look forward to seeing you in the workshop again that starts at 12:30. So thank you very much to Linda and Wendy for getting us started and rolling. Liz, if you don't mind, we're going to start the morning with a poll, with a couple of polls. This will just sort of help us frame our minds, understand where everyone's coming from. You'll see 2 questions posed in there, and we'll give everyone a quick opportunity to have a bit of a go at them before we jump into our lightning talks. The first question you'll see in there is, thinking about your usual work, how would you rate your own level of experience with digital health? Because we do appreciate that this is going to be different for everybody, and this gives us a bit of a temperature check for who's on the line today. So our second question, as I can see some of you putting your answers through there, tell us your attitudes towards digital technology or health informatics in relation to your research. And you can see those options there. And we'll give everyone just a minute more for that, and we'll have a very quick chat. See, about half of you have popped in your little votes. And I think as we can sort of see there, I'm not too surprised. I sort of thought, given our current state of play and the reasons for doing this event today, it's perhaps not surprising to me that some of us feel that we have some experience, but not a great deal. But certainly we're starting to gain some exposure. So again, hopefully that's even more of a pitch for the reason to be online today and be a part of this event. Let's have a bit of a look at question 2. How would you describe your attitudes towards digital technology? If we can, if everyone can see those there. How would you discuss your attitudes in technology and health informatics in relation to your research? A good majority of you actually are actually already working on a digital health project, and that's fantastic. This should certainly help to advance some of those ideas. And again, I think we were probably quite expecting some of us to have some fantastic ideas, but not knowing exactly where to start. So that's great. All right. I think that bodes very, very well for where we're at today. And hopefully, as you'll hear from some of our speakers, which I'm about to introduce, and our panel, you'll find that should prove very, very useful for you. All right, so thanks for filling those out. Okay, let's jump into some talks. So our first session of the day, I'm about to introduce our lightning talks. This is our first session of the day. These are our researchers and colleagues from here within our School of Health Sciences at Melbourne University. And for those of you who don't directly have an affiliation or come from our school or the university, the School of Health Sciences at Melbourne University is representative of the departments of speech pathology and audiology, social work, physiotherapy, nursing, and optometry and vision sciences, although we're very welcoming and hope that we have some people on the line from various other medical and allied health disciplines. In our lightning talks, you're going to hear from a researcher from each one of our departments who's actively working on a facet of digital health research to share their experiences. And what we asked each of them to do for you was to share with you the problem they were trying to solve, why they thought a digital health approach might be useful for working on that clinical problem, perhaps share some challenges they've encountered, maybe talk about some funding considerations, and lastly, give you some tips. We're hoping to have some time for some Q&A, and as I said, please do, if you have questions, post them to the chat as they go. Hopefully we'll have even 10 minutes at the end of our lightning talks to go through some of them, and we'll do our best to get to them, and alternatively, you can contact our speakers after the event. So I'd like to firstly welcome Associate Professor Karyn Galvin from Audiology and Speech Pathology to give us her talk. So Karyn, if you're there and ready, pop your video on, and we can give you an opportunity to screen share. And the floor is all yours. There you go.
Good morning, everybody. Thank you for the opportunity to share some of the work that I've been doing with colleagues from the school and from the centre, and also from each of the largest cochlear implant clinics in Victoria, South Australia and Western Australia. Cochlear implantation provides access to sound for people with severe to profound hearing loss. So by definition, by the time somebody receives a cochlear implant, they've already been living with a significant disability, which has impacted their communication, their social life, their work life, and quite likely their physical and mental health as well. To give you a personal feel for that, I'd like to read a description from an adult who received a cochlear implant. Her sense of self and the world she knew before surgery disappear, and she is thrown into an alien, surreal existence. Pat struggles to come to terms with her changing relationships with others and with herself. She is exhilarated by all her sensory gains and her feeling of being more connected, but is distracted and overwhelmed by the intrusive noise and confronted with the painful reality of her own disability, past and present. So that's a summary of outcomes from a phenomenological study with the actual cochlear implant recipient as a co-author. So it sounds quite dramatic, but that actually is the experience for people who receive a cochlear implant, particularly in the first 3 to 6 months. So what was the clinical problem we wanted to solve? Well, there were 3 drivers for this clinical problem. First of all, as I've just described, the audiological support needs of adults who receive a cochlear implant are very high in the first 3 to 6 months post-operative. The other issue is patient numbers. There's about 900,000 implant users worldwide, but this is predicted to increase by 10% per annum for at least the next 5 years. So that's driven by technological improvements, improvements in access and funding in countries that have had cochlear implants available for a long time, but also in many countries where cochlear implants are newly available. At the moment, surprisingly, the market penetration for cochlear implants is around 5%. So around 5% of people who could benefit actually have a cochlear implant. So we expect a lot more cochlear implant users in the future. The third driver is the available workforce. There are just not enough experienced and qualified audiologists to work with people with cochlear implants. So just as an example, the latest World Health Organization results indicate that most countries in Southeast Asia have one audiologist per million people. So that's not one audiologist with cochlear implant experience, that's one audiologist to provide hearing care for 1 million people. So that's obviously quite limiting. So that brings us to the clinical problem. The current face-to-face clinical service model is both outdated and unsustainable in terms of patient numbers, the amount of service that's required, and the number of people there are to deliver that service. And this is the clinical problem we wanted to solve. Our solution was to propose a mobile device app that would provide informational, psychosocial, technical and clinical support to adults who receive a cochlear implant in their first 3 to 6 months post-operative when those audiological needs are highest. Our motivation for taking a digital angle was that it would allow us to provide flexible support that could be individualised to the patient, that the patient could access night and day and in any setting that they wanted to access that support. Using a digital tool, we could provide support to more people, and it also gives the very important option of combining app-based care with face-to-face in-clinic care. So the app-based care can supplement the in-clinic care. It's also an approach that would be adaptable to supporting patients in lower resource settings. So we've actually already had discussions with clinical audiologists in India and China and Malaysia about that as a potential future direction for us. The challenges we've faced so far have been funding. Funding has been the biggest one. We haven't actually been able to receive a large amount of funding to progress this work. Also distinguishing a proposed app from branded digital tools from cochlear implant manufacturers. So they do have their own digital tools, but they are meeting the needs of the manufacturers. So it's tied a lot to getting people to purchase replacement parts, for example. And also most cochlear implant clinics worldwide provide 3 or 4 different brands of cochlear implants. So a manufacturer app that only works with one brand just really doesn't help them very much. And there's also differing reimbursement models for clinical services across jurisdictions. So that means the role for such an app would really vary in different jurisdictions, and that becomes quite complicated. My tips are to form partnerships with active clinicians so that the digital tool you develop is both clinically useful and usable, to upskill yourself in digital health more broadly, to utilise University of Melbourne IT students because that can help you get some of the legwork done, and to plan pilot studies which will feed into a longer term digital health development plan. And that was all I had. So thank you very much. I hope I was under 5 minutes.
That's okay, Karyn, pretty perfect. So I think that's why rehearsing was very, very good for us the other day. So thank you so much for that. If you could unscreen share. I hope everyone on the line, as you go through these talks, you start to realise obviously that colleagues might be doing slightly different work, but it might overlap with yours and spur some ideas, and maybe you're going through some of the same challenges or their tips help, etc. So again, just a quick reminder, if you do have any questions for our speakers, please post them in the chat and we'll try to get some of them at the end of these sessions. But I'd now like to introduce Dr. Suzanne Kapp from the Department of Nursing to give her talk. I can see Suzanne there. Thanks, Suzanne. And I will pass to you. The floor is yours.
Hi, morning everybody. I'm really pleased to be talking today, so thanks for being here. I'm going to talk about digital wound imaging and measurement today. And the clinical problem that I wanted to solve was how we could accurately record and measure wounds. In my clinical and research practice, I would hear from the patient that the wound's not healing, from the nurse that it might look smaller or bigger. And I was always thinking, well, how can you really tell? And this arose from the fact that we were using fairly rudimentary ways to measure wounds. So we would use a tape measure to measure length and width, which of course is very useful if you have rectangular or square wounds, but we don't tend to see those in our practice. Or we would use tracings. And as you can see this one on the screen here, it's a fairly basic way of trying to work out how a wound is healing, and the quality of those vary, and also the inter and intra rate of reliability with tracings is generally poor. So we had a situation where we could not accurately quantify wound healing, and we want to know if wounds heal, but we also want to use that information to inform our decision making around treatment. This sort of documentation was fairly poor, and it was difficult to share this type of information with the interdisciplinary team. And in terms of doing research, it wasn't a very accurate way to measure our outcomes, particularly when we were interested in wound healing. And as you can see from this wound picture, a picture tells 1,000 more words than the tracing or a length and width ever will. So we had digital imaging, but we needed more to be able to measure wounds in an accurate way. So over the last 10 years or so, we've seen the introduction of systems that can accurately analyse and track wounds. And here are a couple that I've used in my clinical practice and my research practice. And they're generally pretty easy to use by healthcare professionals and even by patients and carers. The options for integration with the EMRs have been fairly limited, but over more recent times, we're seeing more sophisticated systems become available. And the one that I've just popped on the screen is called Tissue Analytics. And we're using this in a study funded by the Victorian Medical Research Acceleration Fund, where we're evaluating remote expert nurse consultation in residential aged care. So with this system, you can use a tablet or a phone, take a photo within the app. The system will calculate length and width if you have a square wound. It will also calculate the perimeter of the wound, the depth of the wound, the total surface area of the wound. And in fact, you can even take a video recording of the wound and generate a 3D model, which is fascinating. And as you can see, when you upload more data over time, you can start to track whether the wound is healing or not. So the challenges so far with respect to research, at the patient level, we rarely get challenges. They're really interested in using the technology. At the healthcare provider level, of course, if we're doing preliminary work and the systems aren't integrated, there is a time requirement and duplication of documentation. At the service level, there's always competing priorities in terms of where they want to spend their research time. So we're continually working on trying to raise the priority for wound care research, and connectivity, unfortunately, is an ongoing issue. From our investigator perspective, whilst we have this technology that can really accurately measure wounds now, we still don't know the best way to calculate healing rates. So we can look at surface area change over time or the linear advancement of the wound edge, but one might be better than the other, depending on the characteristics of the wound. And at a system level, the integration and of course the longer term sustainability and scalability of the use of these systems is challenging, but that's why the preliminary work that we do, such as our aged care study, which involves feasibility testing and a pilot trial, is so important. And in terms of considerations, my successes come with the system developers and the wound product industry who have a vested interest in this type of technology, and also philanthropic organisations. And in fact, we've even received funding from state and federal government to utilise these types of systems within larger studies. And for the future, I think with the Royal Commission into Aged Care Quality and Safety, and the fact that wound care and the quality of wound care that's provided in aged care is suboptimal, means that those grant schemes that are funding aged care research are going to be really important, and future targets such as the Medical Research Future Fund. And in terms of tips moving forward, I think, think ahead and time your opportunity. With this particular example, our technology was really good 10 years ago. We started to see great systems, but now the systems are even better. So it's a really good time to be investing in this type of work, and engage with your key stakeholders. The research that we do and the areas that we prioritise should really be driven by the patients and the informal carers who also do a lot of wound care in the community. So we must engage with them and include them in the team, build the team, and that will help us to create a shared vision which hopefully sees the success of this innovation in the future. Thanks for your time.
Thanks, Suzanne. You can unscreen share as well. No, thank you so much. Again, another fantastic project, and nice to see your work progress and evolve in this space as well. Let's get going. So now it actually gives me great pleasure to introduce Dr. Marianne Coleman from the Department of Optometry and Vision Sciences. Over to you, Marianne.
Thanks very much, Mark. It's a privilege to be able to chat to you all today about digital health research that's happening in optometry. Just a quick tag back to Linda's mention of the School of Health Sciences hubs. I'm affiliated with the Optimising Health and Wellness Hub, but I also work for the Australian College of Optometry, which brings me on to the clinical problem that I wanted to address. So basically, the clinical problem I wanted to solve was the organisation I work for is a public health organisation that provides affordable eye care to Victorians living at social and economic disadvantage. Our clients are complex, often with multi-morbidity, and we wanted to look at whether it was possible to leverage our extensive regular eye examination records, which are held within our digital health record system, to evaluate eye health outcomes over time and the impact of new interventions and services. So this does pose a few questions. We have a lot of data. Is it possible for us to make this routinely collected data available to support public health research and in the area of eye disease? The answer is yes, it's possible. We can de-identify data and submit it to a secure data repository with its own research ethics and governance framework to allow other researchers to apply to access and use the data. So we are hoping to become the first optometry organisation to contribute data to the University of Melbourne's patron data repository, which is normally used by GP practices. But this poses its own questions, namely, what data should we be submitting? What eye health data that is routinely collected in optometry practice is useful to eye health researchers? So to solve that, we were looking at doing a consensus exercise with eye health researchers to identify which metrics we should be submitting to a repository as part of specifying a minimum data set to be included within that repository for access. However, there are also key challenges to making high quality eye health data available at scale. And as part of that, we wanted to also conduct a similar exercise with clinical optometrists to identify what electronic health records are in use and how they record eye examination data within these systems. So why take a digital angle to this? I inherited a clinical records data set, which was built from our data here at the college. And my experience was that the data within it was not pretty. The data set needed a lot of manual processing and cleaning. Not everything in it was actually useful or relevant. And there were also a lot of usage of things like free text. So there are new technologies available to automate the de-identification and extraction of electronic health records data, and this can help to address some of these challenges. But at the end of the day, using data that other people have collected can often be quite difficult. So in terms of the challenges I've faced so far, the free text data includes diagnoses, comorbidities, management plans. We need this data to make the other clinical data that we collect context-based and useful to eye health researchers. So this can carry its own difficulties. If we can get this data out, that opens up opportunities for us to do things with the free text, such as the natural language processing mentioned by Wendy earlier. But there's very much a garbage in, garbage out kind of philosophy for this sort of thing. And so this free text data needs a lot of annotation to allow these processing techniques to do their job. So it's a big piece of work. And there's not many people doing this with optometry data at the moment in Australia or elsewhere. It can feel a bit of a lonely road sometimes. There was a national vision research prioritisation exercise, and the strengthening and leverage of information systems didn't even make it into the top 10 priorities. So there's not that many people thinking about it at the moment. And it's one thing making the data available and putting all the work into that, and it's another for it to be actually used. So the other important thing is about how we're going to assess the impact of making this data available and how is it used. So I'm new to this area, and I'm finding it's the tentative steps along a very long road. In terms of tips, talk to people, because they can make that journey easier. These are all organisations within the university that I've really benefited from speaking to and working with, including the Centre for Digital Transformation of Health, who are running this event today. Go to things, There are a lot of organizations that deal with health informatics and electronic health records data. They do webinars, they have mailing lists, you can sign up and hear about funding opportunities, all of that sort of thing. I'd just like to close by briefly spotlighting some of the other digital health research projects that are happening across the Department of Optometry and Vision Sciences at the university. Here's all the contact details for anybody that you're interested in hearing more from. Please do feel free to make use of those. And thank you very much for your time.
Marianne, thank you very much. Those tips were great. I think some of those resources and those networks that are actually within the university will be invaluable to some people. And just to mention that as we move into our panel after this session, you'll hear a little bit more, most likely about Patreon, about MDAP, because a couple of our panelists are very intimately involved at the top levels of those networks. So thanks for sharing that, Marianne. So moving on, I'd like to now introduce Professor Lynette Joubert from the Department of Social Work. So Lynette, if you're ready to go, we could get your slides going.
Right. Well, good morning, everyone, and thank you very much for this opportunity to talk to you about the development of an app for scaling up supportive care for the informal carers of people with disability. And I'd like to acknowledge my co-researcher, Nathan Grills, from the Nossal Institute of Global Health. So what was the practice problem that we were really interested in? And it really rested with answering the question, can informal support systems be translated into digital applications to support people with disability? And I think what we were really looking for was an app that could encourage interaction and not just provision of knowledge or as an audit of activity. And I think psychosocial care involves complex interventions. And so what we really drew on was a diverse team of people with many different kinds of skills so that we could work on the way in which we could actually bring these complex interventions into a digital space. And one of the biggest challenges I think here was, how do we include networks and systems of care in a digital application? So we've done research using a range of different methodologies. The first one was qualitative research looking at the lived experience of carers. Then we looked and utilized co-creation methodologies. And finally, we did a feasibility study with carers of a local organization, Urala, and did this through a social media platform. So at this point, we've got to the stage where we feel quite confident about our prototype. And one of the sort of issues that we really have drawn on is our global partners. So this study actually started in India, and we came with the same issue there, where informal carers are providing most of the support and care of people with disability, family carers in particular. And so we realized that to develop an app that was so complex and that had to bring together these multiple issues, it was no good us starting from the issue that we were well aware of, but that we should actually do the research first, and that the app would grow out of this research. And in fact, that is very much what has happened. So in India, a survey of 879 people was carried out. We looked at lived experience, feasibility, acceptability, and did a lot of work with co-creating in the Panchayat, the area within which the study took place. And so you'll see it in my slide here, which is a busy slide, you'll see the geospatial mapping, which has now become part of artificial intelligence in the app that has been developed by the Roger Geary College of Social Science. So all this work has culminated in an app in India. We are still at the stage where we think we know exactly what the content is that we'd like to put in the app, but this development of the app will be our next stage of our local research. So I think one of the terms, or the set of terms that I became very familiar with, was global plus local does definitely equal glocal. And in fact, that is not a spelling mistake, which people often think. But in fact, a lot of the information that we realised from the survey and from the interviews and the lived experience of carers came up again in our lived experience study here, and we were able to learn and interact from both these sets of data. It's very interesting also just to mention that at the global, the Google conference in May of this year, a study done by Google Health researchers on carers in the USA, over 200 of them, also came up with results that synchronized a lot with our study. So this is a global issue. And I think we can learn a lot from the experiences across countries and the very important need for digital applications in this area. One of the biggest things about providing support services is their intensity of the type of experience. So being able to extend the services of organizations through digital applications is a critically important factor for reaching people who otherwise might not have got adequate support. Our funding to date has mainly come from seeding grant money. I was fortunate to have money from the Melbourne School of Health Sciences International Fund. We've also used the Mary Glowry Scholarship to bring scholars out from India onto our campus. And the Melbourne Disability Institute seed funding has supported the local study. We are fortunate now in India to have obtained the support of a large international philanthropic organization who have said that they will give the technical support to take the app in India into a model that will be able to be implemented. So it'll take it to the next stage of development. I think one of the biggest learnings that we've had is their pathways of development, especially in this kind of complex intervention moving into a digital application, and models. A big part of this research has been capacity building. Several master's students in India of social work obtained their degrees. 2 of the people working on the project were given a PhD scholarship from the Indian government. And here in Melbourne, I'd particularly like to acknowledge the work of James Simmons and Samantha Gross, 2 of our students on fieldwork placements. My big tip is in complex interventions and digital applications, look at the context. Who are the team that are going to bring the diverse skills? Where is the community where you're working? Because that geospatial mapping is something critically important, and above all else, co-creation with the people that you are providing the app for. I'd like to just say that there are emerging projects coming in the Department of Social Work. These are the 2 most recent digital projects that are happening now. And I'd like to acknowledge my partners across the university, the URALA partners who are working with us, and also our global partners in India. Thank you very much.
Lynette, thank you so much. I think, yeah, it's quite obvious there, the reach and spread of that, and also how far those benefits can actually travel both directly and indirectly. So thank you for sharing that, and look forward to a few questions. So last but not least, I'd now like to introduce you to Rachel Nelligan from the Department of Physiotherapy. Actually should be saying soon to see Dr. Rachel Nelligan, because you've actually got your completion seminar very shortly, so perhaps the timing for this is perfect. But Rachel, thanks so much. I'm going to hand over to you, and you can screen share for us.
Thanks so much, Mark. I'll just get this up. So it's a pleasure to be presenting on behalf of the Physiotherapy Department today, and also my supervisors, Professor Kimbernell and Professor Rana Hinman. And I'll be talking today about a digital program we designed to support people with knee osteoarthritis start and stick to regular exercise. So the clinical problem we wanted to solve was we know that exercise is a key recommended treatment for the management of knee osteoarthritis with proven benefits on symptoms, and exercise can also help prevent costly joint replacement surgeries. However, people with knee osteoarthritis aren't exercising, and this is for a range of reasons, including that people have difficulty accessing appropriate evidence-based exercise treatment, and also people find it challenging to adhere or stick to exercise in the mid to long term. So we came up with a solution to this clinical problem, which was a digital solution containing a website, which we developed, which contained evidence-based education about knee osteoarthritis and exercising and managing symptoms. And this website also prescribed a fully self-directed 24-week knee strengthening exercise program. And to support the strengthening exercise program, we also developed a 24-week behaviour change text message program. And this is where people would receive text messages on their mobile phone to help them stick to the exercises prescribed in the website. Excitingly, this clinical trial has been completed and results have recently been published in JAMA Internal Medicine. And in this clinical trial of 206 people, we found that the combined digital intervention did improve clinical outcomes at 6 months. And this demonstrated that it's an effective option for delivering good quality exercise management to people with knee osteoarthritis without requiring a health professional. The reason we took a digital angle was that the digital approach helped us address some key fundamental issues which were underlying why people weren't exercising. Digital angle helped us improve access, open access up to evidence-based treatment. It was novel. There was no program similar to this that was freely available in Australia or internationally. And this approach is also scalable. So this will enable us to reach a lot of people easily. And this is really important because we know that the prevalence of knee osteoarthritis is predicted to become unsustainable for healthcare systems by 2030, so very soon. I don't believe we faced any significant challenges in the development and evaluation of the study, but I think that the things more to highlight here is regarding implementation of the intervention. There are definitely things that have taken a lot longer than we would have anticipated. The first being the world of IP or intellectual property. So as people from other universities started reaching out and wanting to use our resources in their own research or in their own populations, we had to upskill pretty quickly on intellectual property and legal agreements. Also, the SMS program we developed, we found that putting it in a real world setting, it wasn't going to be feasible for us, as there would be ongoing administrative support needed, which we couldn't provide, and also ongoing costs. So we have recently developed this SMS program into an application, so we can provide it free of charge for people and also without administration. And finally, identifying and connecting with early adopters, so people that will use your intervention in the real world, has taken a lot of time and is something that is still definitely ongoing for us. Tips from our journey would be to develop your implementation strategy at the start, so at the same time that you're developing your intervention. And this also involves getting your key stakeholders involved early. So include your end users in the development of your digital intervention, but also include the end users, so in our case, people with knee osteoarthritis, in your implementation strategy. Reach out to the RIC team, which is the Research and Commercialisation team here at the University of Melbourne. They provide wonderful advice and support, so do that early on. And also start connecting with your early adopters early in the process, and start building those relationships at the beginning of intervention development and throughout, and that will really help the implementation at the end. So thank you very much for listening, and I look forward to answering any questions with more detail.
Rachel, thanks so much. There's a great sort of succinct outline of your research project. And yeah, again, it goes to show, having been a PhD candidate, how much work you actually get done in that period of time. But I'm sure you're no doubt looking forward to expanding it and seeing it progress a little bit. So, okay, look, thanks everybody. That was fantastic. I think from the perspective of seeing the diverse range of research going on within the School of Health Sciences itself, I think we were talking about, and I'm sort of addressing the speakers here, when we started to put this session together, I don't think we deliberately tried to necessarily have such wide coverage of digital health, but I think it's, you know, we can see we've had mobile health and development of apps and the connotations of social media there. We've got projects going on around electronic medical records and data and remote monitoring through, you know, some of the almost telehealth implications to Suzanne's work as well. So we've got a real broad coverage, and hopefully those talks inspired people as to the type of work you could be doing in this space. So again, I'd like to thank all our speakers. I'll ask our speakers if you could all turn your videos actually back on, and feel free to unmute yourself at the moment if you like. We've got a little bit of time for questions, which is absolutely fantastic. We've had a few come through, so I think we might jump into some of them. I might start with you, Lynette and Karyn. If you're both happy to expand, because you both talked a little bit about working with students at the University of Melbourne, and that might be a great way to support researchers in the early phases of the research to develop some traction. Maybe you could both just talk very briefly about those experiences. Lynette, go for it.
First? Shall I
please.
go first? Last year, of course, due to the COVID experience, many of our students moved to doing field work that was research-based. And I was fortunate to have 2 students consecutively on this disability project. And I think that as they said that they were able to integrate the tasks given to them from their fieldwork placement with the learnings and being able to integrate that with the experience of being on the project, and then the unique learning that they experienced from this participation. So it was very much a situation where we were able to integrate what was required of them on fieldwork with the practice and the nature of the project, and then what they felt they experienced. So part of the skills that they learned, of course, was interviewing someone online, learning, of course, about this whole field of practice, interacting with the community partners. So there was a whole series of new skills that they were able to learn and practice, as well as, of course, learning about the whole research context and digital space. So I think it provided a very positive learning experience, and they also contributed very much to the project.
Thank you very much, Lynette. Karyn, anything to add to that?
Yeah, I've actually involved specifically some IT students to help with the digital side of things. So when we were very early on in our planning this project, I co-supervised a Masters of Information Systems in Health student who wrote a technology roadmap to just look at what was out there and what the future was for digital tools in the cochlear implant rehabilitation area. And in a different topic, a different app web app that was actually developed last year, I worked with Masters of Software Engineering students who actually had a team of 10 people, and with input from myself and another clinician, they, as part of their project, developed a web app. So there's various different subjects out there where the students, the IT students, are required to do some type of project that can be led by a clinician from health sciences.
That's great. That's a great avenue for people to consider. We've had thanks, Karyn and Lynette. We've also had a question come through, and actually, Rachel, I'm going to flick it to you first. I think you all touched on this. It was kind of a key theme with your talks, but Rachel, you spoke specifically about engaging with early adopters. I think again, yeah, that was common, uniform against all the talks. Can you elaborate on that a little bit more, and maybe some tips on how you go about that?
Yeah, and early adopters being the people that will early on start using your intervention. And for us, early adopters, of course, were people with knee osteoarthritis, but also looking at impact of the research. We started connecting with people in public hospitals, in private health insurers, for seeing where we could get biggest reach with the intervention. And for this particular project, we started connecting with these key stakeholders through the TRAM program that the University of Melbourne runs. So that's the Translating Research at Melbourne Accelerator program, which I was part of. And a big focus of that program in connecting with key stakeholders and early adopters was really connecting with these people. So calling people up, trying to get meetings and really discussing what we call problem solution fit. So what are the problems that these people and these companies and institutes are facing, and does our digital intervention actually solve problems for them, and then working from there, and of course adapting the intervention to suit their needs as we went.
That's great. That's good advice. I think a lot of people can apply that to their work. Thanks, Rachel. Yeah, that's perfect. Marianne, you touched on one of your studies about identifying minimum data sets and what data should be being collected. We've actually had a question come through kindly from Linda. You talked about obviously the Delphi project, or you touched on it. The question was, did you use a Delphi process to undertake that work? And could you expand just a little bit on that project?
Yes, so we are using a Delphi methodology to identify consensus amongst eye care researchers about what metrics they consider to be absolutely essential for undertaking their research. So this is the first phase, is to get their views. We will also be presenting the same set of metrics, which are commonly used, commonly collected data to optometrists to find out how frequently they record these and also how they record these. This is a methodology that's been used in the UK to specify a minimum data set there, and we are adapting this for the Australian context, which includes other factors such as Indigenous status and healthcare insurance status, things along those lines. So basically, yes, we are using this Delphi methodology, but the other point to consider is that there is core outcome set development underway in Australia for a number of different areas of eye care. So this extends to pediatric ophthalmology and strabismus, but also in other areas such as stroke recovery and rehabilitation as well. And some of these areas have overlap with the area of optometry as well. So it's important to not duplicate work that's already been undertaken in this area. So that's where we are at this present moment in time. In response to Linda's follow-up comment about inclusion of patients. So there's no patients included in this set of rounds. This is a completely unfunded study, and we're undertaking this basically through the goodwill of collaborators and a volunteer based at the Australian College of Optometry. So there are certain limitations to what we can undertake, including appropriate remuneration of patients for their lived experience and input into this kind of work. So it's something that we would love to do in the future, but at this present moment in time, it's not something that we're able to undertake, but hopefully we can do this work in the future.
Thank you, Marianne. That's perfect. Thank you very much for addressing that question. In the interest of time, we have time for one more question, and I'd actually like to pose this one to you directly, Suzanne. Your work is certainly sort of seen, as you said, the evolution of the different systems, etc. And I think when we talked about putting this project together and putting, these talks together, you mentioned further work planned to use artificial intelligence that might actually complement your project and the decision making that comes from the solution. Can you talk a little bit about that and what the next steps are there?
Yeah, absolutely. Great question. So we, in this aged care project that we're doing, funded by the Victorian Medical Research Acceleration Fund, we're working with international collaborators, biomechanical engineers who develop algorithms for artificial intelligence systems. And what this project enables us to do, and it couldn't be done without our project, is to provide digital images to this group who will then be able to develop this machine learning algorithm. And the idea is that, not in this project, because this project is purely to provide the images so the algorithm can be developed, but ultimately the plan is that there is an artificial intelligence type system that will complement decision making. Whether that's used within an application that analyses and measures wounds is probably future consideration, but we know that the expertise that nurses have when they provide wound care is variable. And if we take a look at the aged care setting in particular, we know from, well, I know from my experience and from the research and the Royal Commission that not all nurses will be experts in providing wound care. So, you know, part of the picture is understanding how the wound is healing and being able to say if it is or isn't healing. And some of those measures that I talked about are really important, but that's only really useful if we have clinicians that can then make changes to treatment and you know, ensure that the wound does have the best chance to heal. So perhaps some of these artificial intelligence systems will fill a gap, or at minimum will supplement the decision making of clinicians. And I think that's just fascinating work. And you know, it's really enjoyable to be involved in that, because that sort of extends the work that we're doing and moves the technology, I suppose, into the future, which is where a lot of this technology is going in the area of healthcare.
That's it. No, I think certainly people, again, it's artificial intelligence is one of those areas that I think people want to know about, need to know about, know that it's impacting everything, but again, aren't really necessarily sure what it's all about and what it means. And again, thanks for clarifying that. And we're certainly going to have people like Andrew Turpin and Douglas Pires, who I can see that are going to be able to talk to some of those facets in our panel, which is great. Look, I'd like to thank you all. In the interest of time, we do need to keep moving today. I do also appreciate, thank you to everyone who's posted questions so far. There were a couple that we didn't actively get to. But I apologise about that. We will do our best to follow them up and address them, and perhaps even have our speakers address them for you after the event. So if everyone could virtually join me in thanking our Lightning Talk speakers. As I said, I think we've got a great bunch of researchers doing good things here in the School of Health Sciences. Stay in touch with them, ask them questions, and hopefully they've given you some tips and things that are going to help you progress your own research. So now, in terms of our timeline today, it's now approximately 10:35. We're going to open our panel very, very shortly. So what we're going to do to give everyone a chance just to sort of get organised, we're going to take this opportunity to take a 5-minute break. Again, might be an opportunity for people to just, again, reheat that tea or make a fresh one, bathroom breaks, etc. And we're going to get started with our what does digitisation mean for health sciences research, and how do we implement our findings into practice panel in 5 minutes, starting at 10:40 on the dot. So thank you again to all our Lightning Talk presenters. I think we might get started here. So of course, as part of this event, we did want to put together an expert panel. The people here on the screen, and I hope a bit of flattery does go a long way, but the type of people that we have up on the screen here and the level of experience and engagement with digital health, this is conference worthy, keynote panel type stuff. So hopefully we're all going to get a lot out of this. I might just ask Andrew and Marie, if you're there, just pop your videos on if you can, please, just so that Basil can add you to our panel. So let's get into this, and I'll introduce you all very, very shortly. So the thing to think about in terms of our direction of discussion for our health sciences panel today, digital health sciences panel, is that when we think about clinical research in the health sciences and perhaps the role of digital health within the learning health system, digital technologies such as electronic medical records, various other connected devices can all be used to collect, to store, synthesize, and communicate data and information. And that's notwithstanding technologies that are actually used to deliver healthcare, as we've seen telehealth being very popular, and I shouldn't say popular, I should say topical at the moment. The process of clinical care informing research, and obviously vice versa, continues to function in an iterative loop, and the ultimate goal being to improve patient outcomes as well as health system performance. So we're here today with this panel to consider, say, what digital is or can be doing to advance clinical research, and particularly when we come from the perspectives of the allied health sciences and nursing, and where those disciplines are concerned. So I'm going to introduce our panelists here. I think we got Marie Gertz. Marie, if you're there, please join us and pop your video on. And Basil can sort that out. So I'll start introducing everybody there. Okay, so I'd like to introduce our panelists and thank them. Again, these are very esteemed colleagues working in the space of digital health, and I think we're going to gain a lot of insights from them today. I'd like to start by introducing, and they'll all introduce themselves and talk a little bit about the work they've been doing shortly. I'd like to start with Kath Feely. Kath is a physiotherapist by background and is the current Chief Allied Health Information Officer, one of only, I'm thinking, still two in the state, Kath, but you three now. Chief Allied Health Information Officer of our Parkville Precinct and has overseen major electronic medical record implementations. We also have here Professor Andrew Turpin, who is the convener of the PetaCampus initiative and the lead of the Melbourne Data and Analytics Platform, that is MDAP, that Marianne mentioned in her talk. And he's also a professor in computing and information systems at the university. I'd like to welcome Dr. Douglas Pires, who is a senior lecturer in digital health, who is also from computing and information systems and also the Centre for Digital Transformation of Health data stream lead. And he has a special interest in artificial intelligence and machine learning. I'd like to also welcome Associate Professor Chris Pearce. It's always great to do any work with you, Chris. Chris is also the former president of what was the Australasian College of Health Informatics, which has now gone on to form a new entity with the Health Informatics Society of Australia, now called the Australasian Institute of Digital Health. And Chris is the Director of Research for industry partner Outcome Health. I'd like to welcome Professor Marie Gertz. We will have Marie join us very shortly. Marie, to many of you, you'll know Marie is the head of the Department of Nursing here at the university. And last but certainly not least, Associate Professor Joanne Manski Nankervis, who is an academic general practitioner from our Department of General Practice at the University of Melbourne, and she leads the data-driven quality improvement theme in the department. I'd like to, in that time, hopefully that we get Marie on board, I'd like to give each of you, our panelists, a big warm welcome again, and give you the opportunity just in a brief, say, minute or so, perhaps just to elaborate on the work you're doing and your roles. So I guess, yeah, Kath, we talked about your forefront role in the Parkville Precinct and the EMR rollout. I might start with you, Kath, if you could just introduce yourself and expand on that a bit.
Sure, thanks, Mark. So I'm Kath Feely. I am a physio by background, as Mark said, but I haven't worked in physio for a while. I always had an interest in working with data, and over the 20 years that I've been working, it's now actually possible to have a job working in data and still be in allied health, which is really great and exciting. I did do an implementation at Western Health, and now I've done a second EMR implementation at the Parkville Precinct, which was really exciting. We are just at the start of our journey, and so now it's really around upskilling allied health teams in their capability around clinical informatics and thinking about those research opportunities that we will have now that we're starting to collect data in an easier way to access.
Oh, that's great, Kath. Thanks so much. And clearly the workforce part of all this is so super topical. That's okay. All right, so I might flick to you, Andrew, next. So Andrew, yeah, get you to give us a little bit more about your background and applying computer science thinking to all this.
Hi, everyone. I started life as a sort of hardcore computer scientist working on text, data compression, the algorithms underlying Google, that kind of thing. But I drifted more over the last 10, 15 years into applied research, particularly in the vision science, human vision. So work closely with Alison McKendrick, who many of you will know, in optometry on clinical testing devices and eye testing. So that's my research area. And then more recently, the last few years, I've been putting together MDAP, the Melbourne Data Analytics Platform, and also trying to organise research computing infrastructure as best as an academic can do those sort of things across the campus.
Thanks very much, Andrew. Looking forward to hearing more of your insights today. Douglas, let's hear a little bit about your work in artificial intelligence. I know you've got a background in genomic variants and genomics, but if you could, yeah, tell us a little bit about what you've been doing, because it will certainly be very applicable today.
Thanks, Mark. I'm also a computer scientist by training. I also did a PhD in bioinformatics, and I'd say that my passion and my work has been dedicated to use AI and machine learning to realize the wealth of health data to generate evidence to support clinical decision and to improve patient outcome. I do have a particular interest in developing tools to interpret the role of genomic variation in disease and disease predisposition and how we can use that information to support personalized treatment as well. So I've been dedicated a lot of my time to develop tools and make sure these tools are available.
hopefully some of those insights and those experiences will resonate with people here, and people might want to have a chat to you after the session, Douglas. So thanks for that. Chris, so you've kindly, we were working with Adam McLeod originally, so kindly thank you, for sort of tag teaming with him. You've got a wealth of experience in this space in primary care, been at the forefront of practice-based research and for years now. So we're looking forward to hearing from you today about what the possibilities mean for allied health and nursing. If you could introduce yourself to the good people.
Yeah, certainly. Thanks, Mark. Yeah, so I'm still a practicing clinician, both in general practice and hospital practice. But I run the academic arm of this organisation called Outcome Health that now provides data analytics and quality assurance processes to 1,600 practices across the country. And the beauty of that is that it allows us to rotate the findings from academia direct into policies, or direct into practices. So we got a grant to develop an AI tool to predict the risk of hospital admission based on general practice data. And once we've got the tool, we just then rolled it around and was able to implement it across the practices. So we try and cut that loop down very, very quickly.
Thanks so much, Chris. And Joanne, over to you, because you've also obviously general practice with an interest in data and again, lots of experience. We'll expand on your work in practice-based research, etc. But if you could tell us maybe a little bit about the work you do.
Yeah, sure. So like Chris, I'm a practicing GP. I work in Parkville Precinct Medical Centre, so not far from the uni. And I guess I've had a long interest, particularly in chronic disease management, but also in antimicrobial stewardship. And I guess my interest has come a lot from, so many people visit general practice for their care, but yet we're a little bit of a black box. And so just adding to what Chris was talking about and the great work that Outcomes Health does, from a research perspective, I'm also interested in the use of data to describe general practice activity in particular, and also how we can use technology to optimise the care that's provided in general practice. And so we do work with Data for Decisions, which is a general practice data repository that we have in the Department of General Practice, and also some programs around trial recruitment and chronic disease management in general practice.
That's fantastic. And as we already sort of even heard from Marianne Coleman earlier in optometry, and myself trying to do some of this work in physiotherapy, I think we're all going to be able to learn a lot from the experiences of GP that have been doing such good things in this space for a long time. Now, I understand we do have a little bit of issue with video from Marie, but Marie, I think you are here, and if you can hear me, I'd very much love you to unmute, because I'd still like to introduce you, because you're a big part of this panel as well. So that's Professor Marie Gertz, Head of Nursing. Marie, are you able to turn your audio on and we could actually get an intro from you?
Yes, can you hear me now?
There she is.
Yeah, brilliant. I don't think you can see me for some strange reason, but thanks for the opportunity to be part of this panel. My clinical work's in the area of emergency nursing, but the research that I've focused on for my entire career has been in clinical decision making, and it aligns with the Melbourne School of Health Sciences Optimising Health and Wellness Research Hub. So in the initial part of my research work, I worked on national triage systems, particularly the safety and quality of those systems and measuring that, and later moved on to doing work into risk assessment, clinical risk assessment in hospitals, again in emergency departments, and more recently still on electronic care planning. So in all of this work, we've been using electronic information systems. In fact, electronic information systems have been in place in hospital emergency departments for 2 decades now. That was the pre-EMR, but we're now into the new generation EMR. So very much a clinical application and looking at nurses' role in their ED.
All right, thanks very much, Marie. Let's get you on mute for now, and we'll get you back. Hopefully with video we might see, but if not, we're looking forward to hearing from you anyway today. So look, let's jump into this great discussion. We've already heard our panelists. I'm not sure if you were available to hear our lightning talks. We heard from our lightning speakers across the different departments of the School of Health Sciences, and And they talked, I think some of the things they highlighted were some of the major factors and things at play that are influencing the landscape of allied health and nursing, you know, from a digital sense. You know, some of the things we're starting to see, as we've heard from yourselves as well, the digital hospitals and EMR implementations and embedding those, both Parkville, Precinct and all of our MAC partner hospitals and beyond. But obviously with this comes more data, as we've signposted here, across so many professions. What can be done with it to improve patient outcomes and service improvement? How do we tap into it for research? The list goes on. And obviously, you know, hopefully we can have a chat today about how we can tap into and connect allied health and nursing to advance research in this space. And I think secondly to all of this is COVID-19. We can't really have one of these conversations without still talking about COVID-19, which continues to challenge us to adopt innovative models of care and incorporate digital health. And so certainly I'd love it if we could touch on elements of telehealth and other connected devices and remote monitoring, given how much allied health and nursing clinicians are thinking about these modalities in this space too. So Kath, I'd like to flick to you first, just based on your experiences. You are a very sort of peak body person representation of allied health in the hospital sector at the moment, with all your experiences around the EMR implementations. With allied health sort of really still just starting to think about the potential of digital data, the importance of standardizing that data and the ways it can be documented and collected. You know, I hope you could maybe talk to us a little bit about why that standardization is so important. You know, how EMR data is playing into all of this. So over to you, Kath.
Yeah, great. Thanks, Mark. Yeah, and everyone remember in the past, we all did our documentation on paper. There's certainly been small research projects, but you have the difficulty of, do I write it on a form and then I put it in a spreadsheet and then I put it in a system and then I do my data collection. So you can see there's a few steps in that process, and particularly cumbersome to look at larger populations from an allied health perspective. So one is, where do I find the information that I need? And then sometimes when I found the information, what actually does it say? I can't read it. So therefore, that all makes it a bit more difficult when you're looking at your research. So what we're really doing in the present is we're definitely moving towards using technology with clinical care, including documenting our clinical activities, outcomes, and there's lots of additional information that's being collected, which we wouldn't have had such easy access to in the past. And this really does lead to that opportunity to capture standardized outcome data on a much larger scale than we have been able to certainly within public health within Victoria in the hospitals. And it allows for bigger data sets, more robust analysis, and over a longer period of time to investigate those clinical questions. Particularly to be able to do that, though, is around that, as already come up this morning, around a standardized agreed data set that clinicians can consider, and ideally that it's actually considered part of your standard care. So it's almost that it links in with a best practice guideline, and here is also our standard data set that would link in with that best practice guideline, so that we are all being able to capture similar information. What that means is then it is because it's part of our standard care, we're going to have a lot more data being inputted into the system. And then the idea is then we'll be able to audit that data, and we obviously have to make friends with our reporting teams at our hospitals to then be able to pull the data out that we're putting in. But therefore your data is collected and it's ready for analysis, and it's really then coming up with the clinical questions. So the standardized data sets could include the types of interventions that allied health provide, clinical outcomes that we're commonly looking at, and also some standardized patient input. So whether it's patient reported outcome measures, or whether we have, for example, if we're running a HEN program, which is home enteral feed, where the patients are actually reporting back to us. So every week, for example, maybe it's important that they send us their weight in. So just thinking about how we can connect with patients to also provide us information and data rather than us actually having to do it all.
Sorry, I was just going to say, I know you sort of signposted it. This was sort of our nice pivot into, you did touch on it, but once we have all this data, I guess at the end of the chain is obviously making life different for the patient, at the end of the pipeline, and you started to sort of go into that. But how can what are the implications of that, and how can researchers I guess, work with their organisations, their hospitals at that level?
Yeah, so I think most hospitals now, or almost all hospitals, have some form of electronic health record. And I don't know if you look at Seek, if the hospital hasn't got one, there's certainly a lot of EMR jobs around at the moment. So it's happening. And I think that people can see the benefits of it. But we have to remember, we're actually only at the very start. If you put in an EMR a year ago, we're still at the start of that information gathering. And what we're really wanting to do is make sure that we get that information in. It's really important that we're getting the right information in, but then it's around using it. So that's where we're at the start. It's around processing it. It's around analysing it and using that information to answer our questions, to provide the knowledge, and then us being able to apply that knowledge. A couple of examples, Austin have actually had electronic documentation for about 10 years in their ICU. And they were able to use natural language processing to investigate whether a physio actually has, what's their capacity for recognising early sepsis in the ICU patients. And so that was a great way to look at information that we've had over a long period and identify how that happens. And another example of a project at the moment at Royal Melbourne, and I saw that Aruska is actually online, but what we're looking at is it's a set of standard outcome measures that we always use, and the population will be same population, but one population ends up on one ward, one population ends up on another ward. We have different levels of, the same type of patients end up on two wards. We have this different levels of allied health intervention across those two wards. We're all taking the same measures, and so then we can really start looking at what is the practice that's providing the best outcomes for the patients. And without being a big, it's not a huge demand on the clinicians who are actually providing the care, because this is just part of their standard assessment that they would do anyway, us being able to look at that. So what we're doing is we're really encouraging, because we're really at the start of our journey, we're encouraging our clinicians to engage internally with their research teams to make sure that we are capturing the information that is really important, but also getting them to start thinking about what are the clinical questions that we want answered. And that's where we're going to need assistance from researchers who are bringing in the different lens on how do we investigate this better.
That's perfect, Kath, and yeah, that's going to, I think, segue beautifully into expanding that conversation, because the timing is perfect. Marie, it's so nice to see your face, and so great to have you online. Hope that's all working okay for you,
Mark.
That's okay.
Challenges of using multiple devices. Never mind.
That's okay. Here we go. But look, Marie, so Kath was obviously talking to us about, where we go, I guess, from A to Z, setting up, EMR, what can be done with it, the importance of data collection, but not just that. As she just talked about, then it's sort of much more than EMR. It's, the EMR is just the start. Posing clinical questions, clinical challenges is really what this is all about. Now, obviously, your research, because you've been working with EMR systems, or even pre-EMR systems, for some time now. I think that leads us beautifully to sort of segue to some of your at the coalface examples, because you've been doing work in clinical decision making, triage, risk assessment, identifying a deteriorating patient. Maybe you could expand on some of what Kath was saying and tell us a little bit about your research experiences in this space.
Yeah, sure. Thanks, Mark. So hospital emergency departments have been digitalised for many years. In fact, nearly 2 decades they were early adopters of electronic information systems. And the early work that I did was actually part of my PhD and spurred on the interest in the area of clinical decision making. And when the triage systems were first introduced, there was a strange approach to, I guess, socialising that idea to emergency nurses. And the core to that was not really aligning the systems to the natural decision-making processes that the nurses were using, nor was it matching up to workflow. And this led to early problems with systems. So the work that I originally did was around standardising that, working in partnership with the Department of Health and Human Services in Victoria in the first instance, and then with the Commonwealth Department of Health and Ageing. There's more than 800 EDs in Australia, and they're in public hospitals. And of course, so it was about making sure that the data that was being collected was matching with the what we call a primary survey, the initial 2-minute assessment that nurses are conducting at point of entry to emergency departments. Now that work's moved on greatly since then, but that system still remains in place, and it's been used to measure safety and quality of care and equity of access to people seeking care in emergency departments. And they also use it to look at different performance thresholds. So it has administrative functions as well. But then when we looked at other components of nurses' assessments, we started looking at risk assessment, and I had a PhD student who undertook work looking at clinical decision making and I guess actuarial versus some of the structured clinical judgments that were being made by nurses to manage and identify people who are at risk of becoming aggressive and violent in hospital EDs. And that work was done by Kathy Daniel at the Royal Melbourne Hospital, and that was her PhD, and that those risk assessment processes have been built into the front end of hospital emergency department assessments. So now we're moving on. We've looked at frequent attenders, people who come to the emergency department frequently, and establishing electronic care planning, and we did evaluations of that. Again, that was at Royal Melbourne Hospital. So most recently, we've been interested in working in the acute care setting in wards and EDs, looking at the documentation of incidents, again, in regards to behaviours of concern and the code grey response. And the work that we're doing around that is trying to capture those high-risk situations, not so much to predict them, but to ensure the documentation's in place so that we can start putting into practice some strategies, long-term strategies around reducing restrictive interventions. And of course, if we have rubbish data in, or the nurses aren't completing the data in a timely way, we're not going to be able to develop systems and approaches to do that. And at the moment, there's a lot of missing data, and so we're working on that piece at the moment. So that's, again, in collaboration with our acute care hospitals in Melbourne and regional Victoria.
Thanks, Marie. No, that's great. And again, I think that segued from what Kath was saying beautifully, because I think those challenges are very, very real in terms of data quality and missing data, etc. And you also started to highlight and touch on the idea of using this data for prediction, which takes us beautifully to Andrew and Douglas. I'd like to flick to you both next, because as we've sort of just heard, once the potential for using digital and devices and EMRs is realised, we're dealing with this issue of large data sets, heterogeneous data sets, and as Marie just sort of touched on, making sense of it really is the tricky part. And she started to talk a little bit about, say going from the analytical to the predictive, and many people I think here today are very interested in the transformative power of data and artificial intelligence, machine learning, etc. So I think, Douglas, I might start with you. You've got plenty of examples and experiences here to talk a little bit about the transformative effect of going from analytical to predictive. Maybe you could tell us a little bit about where your work fits in with that.
Yep, so I think the large scale availability of data and data that has been collected, what it allows us now is to employ advanced computational tools to actually realize the wealth of this data to transform the way we treat patients. And that's fascinating, and it's very exciting to live in a moment like this, but it also brings up a few hurdles that we need to be able to overcome to actually apply artificial intelligence and machine learning to the benefit of health. And something that really resonated with me that Kath already mentioned, and Mary as well, is data quality. I think we have three main hurdles to go from analytical to predictive. The first one is really data quality, because for machine learning in particular, if you have rubbish data in, you get rubbish predictions out. So your prediction is only as good as the data you provided, because machine learning is all about learning from experience, learning from historical data. So we need to make sure we have high quality data. So things like missing data, noise, and lack of standardization, as Kath put it beautifully, it's very important to solve these issues in order to really leverage machine learning advances. And it's really a hurdle on AI. I tend to say to people that 95% of the time, if you're working with machine learning, you handle data 5% of the time, you're actually developing the predictive models. And that's the scale of the importance of data quality in there. I think the second aspect that is also relevant is validation. One of the easy issues that occur with machine learning is overestimating performance and what we call overfitting. So it's really easy to fit noise rather than the actual pattern that we're looking for. So we need to establish rigorous ways to validate data before translating it into clinical scenarios. And perhaps the third important issue I would say is usability, making sure what is developed is actually easy to use. And my research has been focused on developing these tools, but making sure they are easy to use and friendly. So what I've been doing is developing web-based applications that are very, very simple to use, that are compatible to multiple different operating systems. So people can open up in a laptop, in a tablet, and a smartphone, and they're easy to use. I think that's the final step to make sure these get translated into a clinical scenario and really change patient outcomes and improve health. And if I can just give a quick example on how transformative these efforts can be, I think it was my first tool that was translated into a clinical tool when I was on my early days of a postdoc at the University of Cambridge. And we were developing a clinical tool to facilitate and improve genetic screening of patients with a rare condition called VHL, von Hippel-Lindau disease. And basically what happens is mutations on this particular gene predispose individuals to a range of tumors, including kidney cancer. And back then, if a patient had a history of VHL, they would be screened, regularly screened. And the thing is that increases a lot of costs, but also increases the risk of overdiagnosis and finding incidentalomas and so on, and perhaps inflicting harm to patients as well. And having a mutation doesn't mean you're going to develop cancer. And what we've done with the AI tool is trying to build a classifier to group mutations into those that are benign, patients can move on with their lives, and those that are actually harmful and pathogenic. And we managed to build a classifier over the course of 6 months. They were quite sensitive and specific, and we were able to categorize this type of mutations, and that then was inputted to, as part of the screening of the Eden Brooks Hospital in Cambridge, and that now it has saved already over £10 million in screening efforts in helping prevent harm as well. So, but that's just for one protein, one monogenic disease out of estimated 8,000 ones, and so there's much more to be done. And so the perspective is quite good.
Thanks, Douglas. And yeah, again, I think some of those things that you were saying, particularly earlier at the start, around, again, it's like what Kath's saying, that data quality, and it's a very real tension. It almost goes to show that it's obviously certainly a job that if we actually want to make sense of the data and apply artificial intelligence and algorithms, that on one hand, yes, the researchers have a role to play in making sure that data is clean and usable. But at the same time, it's probably also our clinical partners that are part of clinical research that have that onus a little bit to make sure the data is of a certain quality as well. But you also talked about user experience and usability of these devices, which is something that's very easily overlooked. I think a lot of the, we'll all attest to on the line here that digital health has a bit of a, if I build it, it'll get used type of thing. But certainly, we often glean over the user experience, and no doubt some of you will have your own thoughts on that. So Andrew, I have a couple of questions specifically for you, but I wondered if you wanted to add anything to what Douglas was saying there, because obviously you've been doing this work in allied health, in the vision sciences. Did you want to expand on anything Douglas said?
Maybe just a sort of a general observation on, as a computer scientist, you're expecting me to say, yes, tech has all the answers, but actually I'm about to say exactly the opposite. What you're hearing here is that a lot of this is a social problem. So to quote Kath said, you have to make friends with the medical record people in order to get the data right. You have to rely on people to clean the data and validate the data and usability. So the tech part of this is actually very small, and a lot of it was developed in the 70s. Actually, the tech has existed for many, many years. There's the social problem of of implementing it and getting it used, which is not my expertise at all. That I'm talking out of school totally. So I'll go back to talking about tech. As this data, just to talk about machine learning a bit, and Douglas might correct me here, I like to think of it a bit like the t-test, right? T-test was invented in the late 1800s, pre-computation, and you needed a couple of numbers and you could look up a table to do your hypothesis testing. These days you can do much more sophisticated hypothesis testing with computational methods, permutation tests, bootstrapping, all that sort of stuff. Machine learning the analogy here is linear regression. So you used to be able to predict from your data using linear regression with, computing the sum of X and blah, blah. These days, machine learning is very sophisticated linear regression, if you like. It allows you to do much more powerful things. And so as a result, you need a lot of computing power, but you also need a lot of data. So if you think, oh, how do I apply deep learning to my research? As a rough rule of thumb, you need hundreds of thousands of data instances, right? So in the old linear regression, you had X and Y, two variables. And so a small amount of data, you could fit a model. These new machine learning models, which do a very good job for some tasks, have millions of parameters, and so you need a lot of data. That's a bit off script there, actually.
No, that's okay. I think these are the sort of nuances when it comes to technology and artificial intelligence and data analysis that I think a lot of people don't appreciate and don't understand, when they're working in this space. But it did give me a thought, Andrew, because I know a lot of your work has actually been in and around privacy, security of data, and I'd also like your opinion on this.
Yeah, so, yes.
Unfortunately, Chris Pearce has actually had to leave us. One of the joys of being a GP and emergencies coming up. But Andrew, I was hoping you could talk a little bit about, because again, with all of this data and us wanting to analyse it, and again, Joanne will be able to talk about primary care, because again, I think this is certainly something that's very interesting or relevant to researchers around the privacy and the security on the data. I hope you maybe expand on that.
Yeah. So continuing my
etc.
Continuing my social theme, once you've got all this data, there's the privacy and anonymizing, and so you can do that at the coalface, but you can also do that algorithmically. There are algorithms for anonymizing data, algorithms for differential privacy springs to mind, for publishing aggregate statistics about data, which doesn't allow any particular individual to be identified. And that's more sophisticated, more complicated than it sounds, right? Publishing a mean or allowing people to query means in data sets can actually expose individuals in that data set. So you have to be a bit careful very careful, of course, not just anonymizing your data, but when you publish aggregated anonymized data, it's not as safe as it sounds. In my own research area, the search engine America Online, AOL, released a query log. So a list of all the queries that people had made to AOL. And they took everyone's name off it, right? So it was anonymized. Within a day, a person had been identified just from their queries. They queried the name of their local shop, the name of their local post office, and then breast cancer. So suddenly the fact that this person had breast cancer had been exposed to millions of people, even though the data set was anonymized. So, these issues are very real, and there's algorithms, computer science approaches that can help with that. And then, of course, cybersecurity and keeping the data locked up is another real challenge. It's a challenge at the university, it's a challenge at the hospitals, it's a challenge everywhere, right? RMIT was offline for a couple of weeks last month, the month before, after a cyber attack. Melbourne has been very lucky, I think, so far. And so this is very active areas of research, and there's mathematical computational approaches that are helping. At the end of the day, there's still a human in the loop, right? So it only takes someone to give away their password, leaves their mobile phone lying around, unlocked, and yeah.
Hence why this sort of research does go under such heavy ethics scrutiny. Joanne, this is obviously very related to the work you've done, of course, as well, because again, you're dealing with a lot of sort of secondary use of, anonymized or de-identified patient data within the primary care space. But I was hoping you might be able to sort of talk to us a little bit about, because it's particularly from the perspective of allied health and I guess also community nursing, we're going to have a lot of people on the line here that are, from those disciplines. I would love to learn a little bit about your experiences, in terms of working in primary care and primary care research networks in particular, and setting up those sort of clinical partnerships for research, because I certainly think there's a lot. As I said, we're trying to do this in physio. Marianne talked about how we're doing it in optometry. If we could learn from your experiences in general practice, that'd be fantastic. How's digital changed the implications of what you're doing, and what's it meant for you as a researcher?
Yeah, thanks very much, Mark. There's a lot in there, so I'll try my best to unpack it. I might actually just start with what is a practice-based research network to start off with, because it's one of those terms that's being increasingly talked about. And certainly in our Department of General Practice, we've got a really strong practice-based research network, BICREN, that a lot of our educators and also general practices are involved in. So really, PBRNs are these sustained collaborations between academics and I guess people on the ground, so our health professionals and practice staff. And they're really critical in helping to develop and identify relevant research questions, working together on intervention, development and co-design, study design and conduct, and then how then you get that resulting new knowledge actually into practice. And so this is really important because people can have lots of cool ideas, but if it's not actually addressing a problem that's occurring, you're not going to get that interest and traction and then translation. So it's actually really, really important because we need to make sure what we're doing is fit for purpose, particularly if we're doing grants and we've got taxpayers giving us money for this. We need to make sure that we're, using that in the most appropriate and efficient way. So we have PBRNs, and certainly in general practice, we've got around 18 or so across the country at the moment, and it's really exciting to see allied health PBRNs developing, and dental PBRN Evident also is very active. So ePBRNs are a subset of PBRNs where, in my case, general practices contribute data from their electronic health records to data repositories so that they can be used for the purposes of research. And this means that sometimes busy practices can feel that they're contributing to research without necessarily having to do lots of stuff. So we have our Data for Decisions program. We have about 116 general practices that share their data with us. And it's really, I guess, important because it helps us in the evaluation of, what is happening in general practice. Can we use the electronic health record data for evaluation of clinical and health services trials? And I think that's really exciting because it has that opportunity to really optimize efficiency of what we're doing. And we're starting that on a trial that's starting in a couple of months' time. And the whole data governance issue around that, though, is massive. And we worked on it for a really long time before we even started, collecting the data from practices. So Dougie Boyle, who's been doing a lot of work in this setting space in our department, has been doing a lot of work on this, about extracting the data, how to keep it safe. We have a data governance committee. So that has general practice nurses, practice managers, computer scientists, lawyers, and it's chaired by a consumer, and we have some consumer reps on it too. And before anybody gets access to that data, not only do they have to have ethics approval, but that committee has to approve it as well. And our general practices that are participating have to display that that they're participating in this program and give patients the ability to opt out. But it's a really big commitment. There's a lot of ongoing work. And I guess the other thing that I would say is, you know, I'm very fortunate. I get to see what this data looks like when it gets to us. And it's really changed the way that I think when I use my electronic medical record. It has changed my behaviour a bit, but it's also really important to have your clinicians or people that use these records involved in the analysis and interpretation of the data, because otherwise you really have a significant risk of coming to some pretty incorrect conclusions. So, you know, for example, the way our electronic medical record structured makes it quite difficult to input some information in some of the fields, and so people free text it. Now, if you just look at that extracted EMR data, you'll say, oh, GPs do a really terrible job at XYZ. Where I know they don't. I just know that they don't put it in the place that, you know, the researchers might like them to put it. And so I think that having that strong partnership between our methodologists, so our health economists, our statisticians and our computer scientists, together with our key stakeholder groups and the people that are actually inputting this data is really critical, because if we lose the confidence of those people, then we don't have these programs. And that would be a real shame.
I think by osmosis, the sort of theme that's probably emerged from today, going back to the very start in our lightning talks and this panel, has been, you know, that stakeholder engagement. I think everyone's highlighted how important that actually is, whether it be, as you've got experience with co-design, Joanne, and involving patients, but also, you know, the people at the coalface that are going to use it, the clinicians, etc. I'd like to pose a question to all of you, because we've obviously talked a lot about data and how data can inform research, but I want to talk a little bit about evaluation and get some of your thoughts collectively on that. Particularly because this is a research colloquium. There is a lot more evidence, I should say, or literature that is starting to emerge, suggesting that we need to look beyond your traditional randomized clinical trials to evaluate digital health interventions. And again, I'm not sure if that's because digital has got so many moving parts, as we've said, heterogeneous data sets, different devices, but I wonder if you have any thoughts on, because again, it's one thing to sort of set up a digital research project. It's another thing to, you know, glean outcomes from it or an endpoint. I wonder if any of you have any thoughts on, you know, evaluating digital health research and the sort of appropriate methods and ways to go about that. Because I said, you know, are clinical trials the right intervention to prove efficacy, or are they not? Does anyone have any thoughts on that?
I might kick off.
Yeah, go for it.
So, you know, I personally think that clinical trials still have a place, and often our interventions will not just be, you know, putting out a digital health product. There's often education and other activities that are kind of bundled together. So I think that they still have a place, but I think co-design and implementation science also have a really important place, because I think one of the things that I've picked up from everybody as well is you can create these products, but it's a very, very different thing to actually get them translated into routine clinical care. And that's where implementation science certainly has a lot to offer us, and is really important. And I guess the other thing that I would say is a lot of these things that we're talking about are expensive. They might need TGA regulation. They might need ongoing updating. They might actually cost our practices to use. So how are our practices going to finance some of these things? And so I think that there's a really important role for, again, our methodology colleagues in health economics and statistics, not to force practitioners to change their behaviour into how they use their EMR, because frankly, we don't have time. But we've got these really great methodologists that can come up with methods to hopefully deal with that as best that they can, and to look at the benefits and the economic drivers of these technologies, so that they don't just, you know, the end of a trial or something say, yep, these are great, but no one can pay for them or afford them because there's no funding model. So I think that that's something that's really important for that policy and practice, is getting those methodologists involved really early along the journey as well.
That's so fantastic, because I mean, again, people on the line here are going to be thinking about research, grant writing, etc. And it's one thing to sort of be able to prove, you know, patient outcomes and, you know, from this RCT, but as you've highlighted there, Joanne, you know, there's so many other factors at play, you know, whether it be, you know, even just evaluation with end users, but yeah, the economic analysis side of things as well, because we've got the kind of health outcomes research, but we've also got the health system performance or health services research angle and improving that as well. Did anybody else want to add to that? Sort of, again, mindful of time, because time goes when you're having fun. I do have an audience question I would like to pose to you all and then get some last minute tips. But did anyone want to expand on that sort of evaluation question?
Mark,
Kath?
I'd just like...
Oh, Marie, go for it. Yeah.
Yeah, I'd just like to comment on what Joanne said, and I would agree with all of that. One of the things that we've always done is observational work at the coalface as almost pre-work to developing our methodology. So we look at what are the clinicians doing. Again, what Andrew was saying about the social and human factors, understanding those things. It is a socially embedded and health systems-based approach is critical to doing rigorous evaluations in this area.
Yeah,
Kath,
and Mark,
go for it, Kath.
I was just going to say, we also spent some time doing user acceptance pre and post our implementation, which with a validated tool, not something that we have just come up with the questions that we would like answered, to like make benefits for what you've just purchased, which is a lot of money. But then it's also then allowing us to make some decisions. What do we need to change within the build? Like, what are the things that aren't working for the clinicians, and how do we make it easier for them moving forwards? And that's been a really interesting. So we've also looked at, we've sort of also thought about from an allied health perspective, what actually, because we have such a breadth of clinicians working in the space, from social work to real scientists with our dietitians, what actually is driving them to want to use new technology, and is it different across the breadth of the clinicians? And so that's one of the things that we also looked at.
That's great. Thanks, Kath. Now, we had an audience question that I did want to pose, and I might start with you, Douglas, or Andrew for this one. I'm assuming, I think it's a question about interoperability, which I think that's a workforce question, a technology question, and a research question. But I think we're talking here about overcoming resistance to integrating, say, patient-facing digital health interventions with medical records, but obviously then putting medical record data into other devices. In your work, have you got any sort of tips, challenges, recommendations around integrating the different technologies and elements? Because that certainly is a perennial issue for everybody. The big I word, interoperability.
I guess I can offer an observation from my role in in the PetaCampus work, trying to integrate university services within the one organisation, being the University of Melbourne. It's been 3 years now, and we've made a tiny bit of progress. I think for me, it's about relationship building and trust building, which just takes time. And that's all I can offer, which is not very helpful.
No, that's okay. Douglas,
I completely agree. I think it's a matter of building the right team and having a multidisciplinary team around you to help you cross those barriers. But they are very difficult to cross, and it's a long process. But it's important to build from somewhere. And I think having the right team and working together is one way to overcome this.
Go for it, Andrew.
And I also said this is not a problem limited to clinical research or anything at all. The Chief Data Scientist of New South Wales, Chief Data Scientist of Victoria, recently I've heard talks from both of them, and the key element they talk about is trust. In their case, it's trust within government, trying to get government data to make decisions. So it's a unsolved problem across many, many different domains.
Thank you, Andrew. Again, in the interest of time, we have actually gone a little bit over, so we're gonna close this panel. And again, I'm going to encourage our audience members to please stay in touch with our speakers. My details are also on the Eventbrite. If anyone would like to sort of submit a question to me, and I can get in touch on your behalf, that's fine too. I'd like to just flick to each one of you very quickly, lastly, you can use it for whatever you like. If you want to plug something, if you want to talk about something, or even maybe just give a tip, you know, to sort of the researchers on the line that are working in this space, starting to work on this space. Any advice? Kath, I might start with you. We'll go back to the start.
I think we've got really keen clinicians, particularly in the Parkville Precinct, who would be very happy to work with others about research opportunities, that's for sure. And now that we have easier access to the data, I think it really is the start of our journey in this space.
Fantastic. Andrew, I know MDAP and all the other networks in the union. Want to give them a plug?
Yeah, so I think Marianne's already mentioned MDAP, and it's come up a couple of times, but there's also the other university platforms. There's Press for software engineering, Niche for biostats, Dougie's group, who was around earlier, Melbourne Bioinformatics. So there's quite a lot of, well, university money goes into supporting and building this research infrastructure. There's a lot of help out there. MDAP, one of our roles is to triage. So you're more than welcome to come to MDAP as your first port of call, and we can point you in the right direction.
Fantastic. Thank you. Douglas.
I would say the Center for Digital Transformation of Health, that could be a hub to connect people. And we do have a pillar dedicated for data science and people interested to actually develop machine learning applications.
Yep.
Get in touch.
Douglas is your touch point. Start with Douglas. Joanne, let's go to you.
I just really encourage or continue to encourage people to think about how they can engage with practices in the community as well as in the hospital system. You know, and obviously nothing happens in a vacuum. I think Andrew mentioned MISH. They've also got their methods and implementation support. So it's about, I think, building that team and working, you know, closely with your stakeholders, you know, from the beginning. And I guess just to say, like, if people are looking at engaging with primary care or general practice to do a spruik, hop onto our website, look at our Data for Decisions program and VicRen, and certainly would be very happy to talk to people in the allied health space that are looking at doing something similar along that journey.
Thanks, Joanne. That's great. And Marie, you wanted to mention a couple of things as well, so floor is yours.
Yeah. Thanks, Mark. I just wanted to highlight the importance of the health workforce. And I guess in the Melbourne School of Health Sciences, we constitute a really large proportion of the health workforce, both the nurses and all the allied health professions collectively. We're about 80% of that total. So it's really important to think about the preparation of the workforce. And in the Department of Nursing, and I know we've got interest from other departments as well, we've been trialling using the EMR, embedding that in our curriculum, and that work's being led by Zarina Tonkins and the Master of Nursing Science team. So we've got the workstations on wheels, we're using the best practice software in simulation, and we're excited about that work because not only because of the opportunities for research into that area, what it means for the health workforce and what it can lead to in terms of interprofessional learning. That's a piece of work we need to look at in terms of our contribution as a university to the broader health workforce.
Wholeheartedly agree. That's fantastic. It's also a nice plug for our work in teaching and learning. And I might use it as an opportunity to mention the complementary telehealth training program that we're also developing at the moment in conjunction with the Centre for Digital Transformation Health and School of Dentistry at the moment. And that there'll be some training modules available for obviously our partners and our students in the not too distant future as well. So again, I'd like to take the opportunity and have you all virtually thank our panelists today. Again, look, I think thanks so much for those insights. These are some great people working in health sciences and nursing across the university that we can all connect into and stay in touch with. And again, as I said, hopefully that's giving sort of budding as well as mature digital health research scientists some ideas and things to think about when they go forward. There are a couple of last things just to mention to everyone. So that concludes the formalities of our morning. Please go and take an hour, a break. Again, have some lunch, have another coffee. We're going to regroup at 12:30. That will be a workshop event led by the Centre for Digital Transformation of Health. They'll be road testing a couple of research projects from a couple of researchers within our community that have submitted expressions of interest. Come along to that if you want to hear that research ideation, teasing out process, hopefully learn a little bit about your PD. Marianne in the chat has also kindly posted what we've also created for everyone is a knowledge exchange wall using Padlet, which is a collaborative whiteboard type style software platform that we use in our teaching. But that resource will be live and hopefully updated in real time as we go. Please jump on in there during your break if you want, and add any resources, links, websites, documents that you think other people will get some value from. So again, I'd like to thank everybody. We're going to see some of you again at 12:30. 12:30 till 2 o'clock is our workshop. And finally, please do join if you're an early career, mid-career, or anybody's welcome. Our 2 o'clock till 2:30 mentor-mentee session with Robab Al-Dolkani, Professor Kathleen Gray, Professor Alicia Spittle, moderated by PhD candidate Luke Davies, to talk about building your research track career. So thank you everyone for a fantastic morning. Thanks everyone.